we will be sharing with you the third webinar of our series, Saving Lives with Autotransfusion, Lessons from the Field, a SISU Global Webinar series. We're excited that you have joined us. My name is Dr. Juan Carlos Puyana. I am an acute care trauma surgeon at the University of Pittsburgh. I am also in charge of the Office of Global Health in the Department of Surgery. And because of that, I have the opportunity to work in many areas internationally related to global health and global surgery. It is a real pleasure for me to accept the invitation from SISU to be the moderator of this third webinar. This is of particular interest to myself and our team because we have actively participated in a program in Kenya that is looking into improving the availability and the safety of blood transfusions in sub-Saharan Africa. So it is quite welcome, the chance of participating in one of the many areas that we think is a potential area of improvement to bring transfusion and autotransfusion to the front field of what is happening in many places in Africa regarding availability of blood and so on. Today, let me, before I go any further, I just want to let everybody know that this webinar is being taped and it will be posted on YouTube to be available for everyone as an educational activity. It's our hope that with the presentation today, you will have the chance to listen to surgeons and physicians who are in the field currently using the autotransfusion system and Hemafuse from SISU. I will introduce our invited speakers briefly, and then we will move on to have them present their cases. The format of the webinar will be that we will open for a short panel of discussions after the two cases are presented. And after that, we will have an expert on the field who has been participating in training physicians and officers in Kenya about the use of Hemafuse, give us a little introduction of what the system looks like and how it works, so that everybody in the audience who may or may not be fully familiar with this will have an idea of the specifics. And then at the end, we'll have an open session for questions where both the users, the speakers, and everybody else can give us feedback so that we can all share and learn from each other about this interesting subject. The program today will consist of two presentations. The first one will be presented by Dr. Khalid Hassan, who will report on the use of Hemafuse in a patient who suffered a ruptured spleen and that was treated at Lodwar County Hospital. Our second speaker will be Dr. Ekiru Kidalio, also from Lodwar County, who will present his experience in a patient who had massive intra-abdominal bleeding due to a ruptured ectopic pregnancy. Dr. Khalid is a general surgeon by training with an interest in trauma, surgery, surgical oncology, and he's currently based at Lodwar County Referral Hospital, where he's in charge of the county surgical services. So I think what I'm going to go ahead is open the presentations, and I will invite Dr. Khalid Hassan to go ahead with the presentation.
Thank you very much for the very kind introduction, Mr. Puyana. Welcome, everyone. I'm going to take us through about our experience with a case which we encountered during COVID last year around mid-August, that's 2020. And we'll share our experiences on how we were able to salvage blood and were able to autotransfuse the patient his own blood, because at the time we didn't have any unit available for typing, and we were able to use a Hemafuse device, which saved the patient's life. Turkana County in general is a very vast area, approximately population about 1 million. That's about 13 persons per square kilometer. And the size is the second largest county in Kenya, of about 77,000 square kilometers. Lodwar County Referral Hospital is located in Lodwar Town, serving all that population, including the Kakuma refugee camp run by UNHCR. Approximately, we have 200 beds, which were shared by a number of wards, ranging from general surgery ward, which shares with orthopedic and plastic wards. We have a maternity ward, pediatric, and medical wards. Also, we have a new block on the kid for 6-bed ICU, which are fully equipped with ventilators and could be able to provide services to this vast population. For case, the initials of IE, he was 23 years, a male, from an area called Namakat, far away from Lodwar Town. He's a border rider. He was admitted on 12th of August last year and discharged on 9th, on 21st of the same month, same year. So his presentation, and he sustained injury following the RTA, and he was seen in an outpatient health center in the small town where he resides. On 10th, he was given some analgesics, they controlled his pain, and he was allowed home. So he presented 2 days later to our facility, the Lodwar County Referral Hospital, with complaints of abdominal pain, abdominal swelling. He also had generalized weakness. He was also mentioning that he's able to hear his heartbeat beating faster. Next. So the examination findings, when he was seen at casualty, our first encounter of patients who come to the facility, of importance was his vitals. The blood pressure was, he was hypotensive, systolic of 73 and diastolic of 50 millimeters of mercury. And he was a bit tachycardic, and he was saturating on room air at 92%. He was noted to be pale. His abdominal findings noted that he had a markedly distended abdomen, which was not moving with respiration. And then he had this mark caused by the accident on the left upper quadrant. And then on palpation, he had this generalized abdominal tenderness with evident guarding, the localized area of trauma. Common thing which used to be done in all times, we do this aspiration to see if we are having hemorrhage in the abdomen or what we have, but it was done and it was positive. At that time, they were not able to do for him a first scan, a focus scan, which could localize where the lesion could be and even guide further. Other systems essentially were normal. So with that clinical examination, we had an impression that with having a mark on the right, on the left upper quadrant, following that trauma, the way how it's presenting clinically, we put it up together and found that and say that this patient is probably having splenic injury, which could be causing him to lose the blood, presented by the unstable vital signs he had at the time. So what was done immediately was 2 large bore IV cannulas were placed. Samples were taken for complete blood count, typing and cross-matching. abdominal ultrasound was also sought. He was given 30 mils of per kg over the first 2 hours of IV crystalloids. NG tube was placed just to allow him, though the patient had no vomiting, but because of the abdomen, how it was distended, and he was being prepared to go to theater, so NG tube was placed. Immediately surgical consult was sought from casualty, and patient was reviewed with result, and was scheduled for an emergency abdominal exploration. One of the slides we picked from the imaging of the ultrasound of the patient showed hemorrhage more on the left upper quadrant. Though it wasn't clear, it couldn't tell the depth, and those pools were not able to be measured at that time. His full hemogram, full hemogram of significance was he had a low hemoglobin level of 8.3 gram per deciliter. His platelets were normal, and his blood group was O positive. But at the time, we had no blood available for cross-matching. So we put up together, what can we do? For this patient, we don't have blood in hand. It's in the evening around 5 p.m. So one of our theater in charge mentioned that we have a device which can be able to harvest the patient's own blood, and we were able to use that device after going through a few things with the in charge. In the he had spleen floating in the abdomen, 5 were normal, and we were able to harvest using the device about 2 units of his own blood, and we autotransfused the young man. That's the image of the device we used, and the in charge trying to harvest the blood, and I was assisting our in charge. So it's an interesting, it has a system of, then a patient was on follow-up, his pain was taken care of, vitals were closely monitored and recorded, and it was evident that his vitals started now stabilizing after arresting the hemorrhage and transfusing the gentleman and giving him fluids. And he was also lucky to be planned for vaccination. So his full hemogram later after 48 hours improved by 1.2 grams, and he wasn't symptomatic at the time of discharge, and he was allowed home on oral hematinics. Here the medical benefits were eliminated because we are transfusing the patient with his own blood. There was no danger of having sensitization. Then it ensured a better oxygen. Keeping blood for some time longer than when it's needed, or not fresh blood, usually the oxygen concentration goes down. So it has better oxygen transfer when we are using the own patient blood at the time of injury. And then we meet those pre-transfusion examinations, which sometimes are a bit extensive and lengthy, were also eliminated in using the own patient blood. In terms of cost to the patient, it shortened the hospital stay, surgery, because a number of times, most of our patients delay, they spend a lot of time because they have to scavenge for donors who are going to replace blood, or even who are going to give blood so that it can be sent, processed, so that it is safe for transfusion. So all that will be eliminated. And even the cost of donor, because they have to send transport to these relatives to come so that they're able to give blood and then replace. So in terms of the facility, the benefits looked at were the demand of having blood in the stores. At least the demands went a bit down when we were able to harvest the patient's own blood and give it back to them when they were in need of it. And then the hospitals, in terms of costs, were able, to have less number of volunteers who are being recruited, conducting these tests, typing the blood, cross-matching it, even transporting and storage it. So all these costs at some point were minimized when we were able to use the autotransfusion. Other benefits include, not limited to economy. Some patients have just believe that, giving out, so transfusing them their own blood, at least something can be achieved. And even the fears of transmitting them with infection, all those are addressed when they're given their own blood. So autotransfusion is not a new phenomenon. It's as old as 1975 when this was being practiced. And there were over 2,000 cases which were reported in the literature with very minimal number of complications. And the autotransfusions, looking at that from those studies, were a bit efficacious, There is also an article dated 1993, which is more similar to our case, and they were able to use autotransfusion for the patient by harvesting his own blood in a case where they had splenic rupture. And they employed different methods of transfusion, which were mentioned. So using the Hemafuse was one of our own methods which we employed. And this was reported in Papua New Guinea. Next. Tim? This is also a case where they use a device to get the whole blood of the patient in cases of hemoperitoneum, similar to our case, and then even in cases of hemothorax. And of significant patients who have been pre-transfusion, the HB were a bit low, post-transfusion HB improved by about 1.1, similar to our case, which was about 1.3. Article which looked at mentioning that blood commodity is a very scarce and very costly resource, and it also transfusion is often required for major cases of trauma, like similar to our case. And these were controlled studies, and in their results findings, they realized that then 3 patients were entered into that control of the control group and 21 into the study group. The groups were equivalent in the demographics. Their details were similar, injury patterns, severity, and then they were able to salvage up to about 1,400 mils of blood. And then the mean number of units transfused in the first 24 hours in the control group was also compared, which was comparable to the case group. Next, please. So this was a study also which was mentioning significance of autologous transfusion during emergency trauma operations, and they realized that intraoperative cell salvage of the patient's own blood provides an effective and a cost-efficient resuscitation strategy as an alternative to getting blood from someone else and transfusing it in these trauma cases.
Thank you. Thank you very much, Dr. Hassan. That was a very interesting presentation. I have a bunch of questions for you, but I will hold them until we have Dr. Kidalio present his case. Just for the audience, I just want to summarize. This is a patient with a spleen injury. That came in severe shock, managed at Lodwar Hospital, and he was given autotransfusion with the device and did very well. This is quite interesting for a number of reasons, and we'll save them Now we're going to move on to the second case presentation. This will be presented by Major Retired Ekiru James Kidalio, who is a Master in Public Health candidate and also the head of the Accident and Emergency and Critical Care Department at Lodwar County Referral Hospital. Previously, Dr. Kidalio works as a medical superintendent at Lorugum Sub-County Hospital and as a medical specialist in the Kenya Defense Forces. So it is a pleasure for me to introduce Dr. Kidalio, who's going to share his experience using Hemafuse, also in a case of severe hemorrhage, this time due to a rupture ectopic pregnancy. Please, Dr. Kidalio, take over.
Thank you. Good evening, everyone. This is a lady, a 30-year-old female who came to our facility accident and emergency unit from a center 60 kilometers away. She came in with a history of abdominal pain and PV bleeding and amenorrhea of 8 weeks. Next slide. On examination, she was pale. What we usually do for any patient is we go for blood tests, including a blood slide for malaria parasites. And you can see the blood slide for malaria parasites was negative. But what was really interesting was our examination findings and our general clinical state. She was pale on examination and the pallor was increasing, and then the abdomen was distended. And then on examination, the abdomen was so tender. And further abdominal examination involved doing abdominal paracentesis, which was positive. Pregnancy test was also positive. This lady was also taken for abdominal ultrasound. An abdominal ultrasound indicated to us that she had a ruptured ectopic pregnancy of the left fundus. And then from there, we started making arrangements to take her for an emergency X-lab operation. What we found out is that on examination, after X-lab, what we found out was that she had a ruptured left ectopic pregnancy and massive hemoperitoneum. An estimated 2 liters of blood was actually lost. Our facility, our main challenge in our facility is getting blood products. Where we process blood for transfusion is 300 kilometers away. The nearest blood bank is in Eldoret, 300 kilometers away. This particular time we had no blood. But then a colleague of mine who had been trained on the Hemafuse, on the use of Hemafuse device, actually at the theater nurse, alerted me that we have an Hemafuse device which we can use to harvest some of the blood, and then we auto-transfuse. As an emergency, we took the lady to theater, opened the abdomen, did the X-lab operation, and then my colleague used the Hemafuse device to salvage the blood in the abdomen. We harvested around 2 pints. And then we transfused to the patient almost immediately. We did a successful salpingojectomy operation. Then we put on the patient on post-operative management of IV fluids, pain management, antibiotics, prophylactic antibiotics, wound care. Then after 5 days, we discharged the patient home without any complications, and then we'll be reviewing in our OBS-GYN clinic after every month. Since then, after 2 visits, 2 scheduled follow-up visits, the patient is well without complications. Yeah. And we are grateful for the Hemafuse device and technology, which allowed us to harvest that blood, transfused it to the patient with an HB of 5.4. Successfully, we did a successful operation, and we released our patient home to continue with our daily activities of living.
Thank you. Thank you very much, Dr. Ekiru. We have a number of questions, and what I like to do right now is I'm going to summarize a few of them and open a brief panel for about 10 minutes so that all the audience gets a little bit of more information, not just about the use of the Hemafuse, which we will ask you to tell us how that went, but also, as important, to share with us some of the clinical aspects of caring for these very difficult patients at your hospital. The first question is for both of you. I'm going to ask Dr. Khalid Hassan to answer first. It has to do with the approach to making the decision to take the patient to the operating room. I think this is very important because one's job is to try to anticipate the need for blood and the need for transfusion. And I'd like to ask you, this question is for both of you, but because both cases needed or were managed in as such a way that they both had a diagnostic peritoneal abdominal puncture to see if there was blood there, even though you also had an ultrasound on both of them. Do you always do both? Do you don't trust the ultrasound? Or why not just do the ultrasound, save the step of putting the needle in the belly, and based on the clinical findings of hypotension, the medical history and the ultrasound, take the patient immediately to the operating room? So over to Dr. Hassan first to tell us a little bit more about the diagnosis and the criteria for intervention. And then I will give the word to Dr. Kidalio.
Thank you very much, Dr. Puyana. I agree with you 100%. People have stopped doing aspirations, assessing whether the patient has peritoneal hemorrhage. It's a long thing which used to be practiced. With the advent of technology and accessibility of using sonography, people have moved to using focused ultrasonography to not only give a clue of having blood or hemoperitoneum or not, or any other type of fluid in the peritoneum, but it can also be able to give where the location of the hematoma is. Is it near these evident visceral organs which are prone to injury? Like, is it near the spleen? Is it in terms of where it is located? And the challenge we had, why in our case, patient was not able to be offered the first option, was the first encounter was a junior officer, and he was sent. Even vitals, despite being placed large valve cannulas, resuscitated, vitals started peaking, but not at adequate level. They thought it was a shock to them, you know, looking at a huge abdomen, the patient is a bit sick, and he was rushed, and they were able to do the scan. But our sonographer was not keen enough to be able to pick at the moment if he was able to give further clue on whether this patient had hemorrhage, and if he could be able to use the first scan so that he can localize where the lesion is and give more accurate diagnosis.
Very well.
So, yes.
So, Dr. Kidalio, any comments about the approach on your group about making the decision and using these two tests one after the other?
Yeah, ultrasound technology in our setup is relatively new. Most facilities, many facilities do not have ultrasound services. So we rely on clinical acumen to make an impression. That's why in an accident and emergency situations, we go for abdominal paracentesis, and then confirm the diagnosis with an ultrasound. You know, though our facilities, we've got so many challenges. Sometimes even you might not get the sonographer to do for you the ultrasound. Or maybe if the sonographer is there, is living in a place which is far away from the hospital facility.
Right.
Then the patient comes in at midnight, struggling to get the sonographer to come and do the ultrasound in an emergency situation takes time. So we usually go as per your clinical argument, you make an impression and then try to make an intervention as early as possible so that you mitigate the situation for a better outcome.
So let me ask you now that I have you there, how often do you see these patients coming to your facility with severe shock due to ruptured pregnancies, ectopic? Is this a common clinical scenario? How often do you see that?
Very common, very common. You can even get 2 in a week, 3 in a week.
3 in a week, wow.
Yes.
And usually, do these patients, how they arrive to the hospital? They need to, do they live close by, or they're far from provided medical care?
All patient is the one I've just described in the case presentation. They usually live far away. Like for example, the center I was saying is 60 kilometers away. It's just a trading center. And maybe that is the nearest she could locate, but maybe she's living some other kilometers far away from that center. So they usually, maybe the lucky ones, they get some public transport to come to the facility, but in most instances they walk or they use motorbikes nowadays, border borders to come to the hospital.
So I understand that having blood immediately available is always a challenge, or quite often a difficult problem there. How do you go about asking for the Hemafuse and using it? I understand neither one of you had previous training on the use of Hemafuse, but someone in the team knew how to use it. What was the process to make it available? And now that you know that it works, how would you like to sort of create a protocol so that everybody is aware and improve not only that they think about it, but they use it efficiently? Who wants to answer that question?
Maybe I can, from my experience, before we got to use the Hemafuse device, there is a team which visited our facility to make a presentation on the use of Hemafuse. Some of our colleagues attended, and then some of us did not attend. But then, okay, being a frequent user of the theater, one of the colleagues who attended the training is the one who had the Hemafuse device. And then that day he was on duty, and then even me, I was on duty. So being aware of the challenges of getting blood processed or even the availability of blood, he said as an emergency, there is an equipment which was donated to us, and we can use it to salvage blood and then give to the patient, and we continue with the operation. So those are actually the convenience of getting access to it. Like for example, being in theater or even in the maternity unit and in the surgical department is appropriate.
Very well. We will come back because the audience keep asking lots of questions, and we had planned to make a brief pause here so that we can bring to the group our third speaker, who has a great deal of experience training people about the use of Hemafuse. So she is I'm going to introduce her. Her name is Emma Muragari. Emma is the Hemafuse training executive for AMREF Health Africa. She holds a Bachelor of Science in Nursing from the University of Nairobi. She's a postgraduate certificate in health professional education at Maastricht University, and now is pursuing a master's in public health at the University of Nairobi. Emma has a lot of experience. She has spent years on education and training, and we will have Emma comment on the technical aspects of the use of Hemafuse, and we'll come back so that the audience has an idea, looking at a video that Emma will take us through, so that everybody has some idea what this looks like, and then we can go back to some of the questions that we have left unanswered purposely, but we will go back to them. Emma, take it from here, please.
Thank you so much, Dr. Puyana, and thank you everybody for joining us today. I can already see the questions regarding how the Hemafuse is used. So we hope that this video will be able to provide answers on how Hemafuse is used to provide life-saving autologous blood transfusion immediately, during, or after surgery. So thank you. So Hemafuse can be used with minimal adaptation to existing surgical techniques. As you can see here, the operating team can still remove the large clots or particulates by hand from the abdominal or thoracic cavity or wherever the pooling of blood may be. So the Hemafuse filter is 170 microns and is very effective at trapping smaller clots and contaminants. However, large clots still have the ability to clog the Yankawa tip or the Hemafuse filter and should be removed by hand. So you need only 3 surgical team members to operate the Hemafuse. 1 to pull and push the plunger, the second to operate the Yankawa tip, and the third to operate the stopcock. So in this demonstration, the Yankawa tip is being wrapped with a gauze. So this is a protection that the surgical team can take to prevent small clots from clogging the Yankawa tip. So first, the Yankawa tip navigator will insert the tip into the middle of the pooled blood. The tip navigator will then avoid inserting the Yankawa tip too deep and coming into contact with tissue or organs, just as you would with normal suction. They'll also avoid placing the Yankawa tip on the surface of the pooled blood. So once the tip is inserted into the pool of blood, the team member operating the plunger will begin to pull back slowly, as you can see in the video. So they'll pull back on the plunger and blood will pass through the filter and enter the collecting barrel. So once the plunger is pulled back to the level of the autoclave tip, the team member operating the plunger will stop pulling back. So at this point, there's air mixed with the salvage blood in the collecting barrel, all right? So Hemafuse allows the surgical team to easily release the air from the barrel via the stopcock, as you can see that. Communication between the team is very, very critical. The plunger operator must let the stopcock operator know when they want to release air from the collecting barrel. So the stopcock can be positioned in a way to release air from Hemafuse. So once the air is released, the team members will confirm that they're ready to fill the blood bag with freshly salvaged blood. So by pushing down on the plunger, blood will make its way from the collecting barrel directly to the blood bag. So it's very critical to push the plunger slowly. So Hemafuse is engineered in a way that it limits the amount of pressure that can be exerted on the blood, and this prevents hemolysis. So key to note is that pushing faster does not cause the blood to enter the blood bag any quicker. So the blood bag is pre-filled with citrate anticoagulant, and the stopcock operator will gently rock the blood bag to mix the freshly salvaged blood with the anticoagulant. So once the blood bag has been filled with blood, the team will communicate to release any air out of the blood bag if it is necessary, and then disconnect the filled blood bag from the system. So the autologous whole blood is now ready for immediate transfusion back to the patient. So blood collected via the Hemafuse is viable for retransfusion to the same patient up to 6 hours post-collection without the need for refrigeration. If there's need be, a new empty bag, again filled with citrate anticoagulant, can be connected to the Hemafuse, and the team can continue to salvage the blood that is pulled internally. So thank you.
Thank you, Emma. That was really very, very good and quite clear. Appreciate how you had take us through the process. I think at this point we can have Dr. Kidalio and Dr. Hassan tell us a little bit about your own experience, how difficult, how easy it was to use, where do you put the suction, what kind of incision you made, and were you happy with how the system worked? Who wants to give us a little bit of specifics about the use of the Hemafuse?
One, the use of Hemafuse, our experience with the use of Hemafuse was quite resonating well, because it's not a very technical and hard device that requires one to be a bit intensive and to be able to use. So just pre-op a few minutes before the surgery, because it was in the evening, we had no blood. We also had a few of our colleagues in theater by then, only 3 of us. Our anesthetist, the theater in charge device, we use saline. How we were able to connect the different parts I've seen in the video, and
So I know that in your case, this patient had been days after the injury. He probably had that spleen rupture and he had the hemorrhage. But were you worried about the patient having other injuries, like a bowel injury? And if that would have been the case, what would you have done? Were you able to rule out other injuries before using the Hemafuse?
Yeah, thank you very much, Dr. Puyana. That's a very interesting question. So one of the contraindications in cases where one is supposed to harvest blood and autotransfuse the patient is if the blood has stayed for a very long time and it's infected, either contaminated with GI content, or if it has become septic, maybe has an open wound and it has a communication to the external environment, and infection ensues, not only bowel injury. So in our case, our goal was to see if we can be able to salvage the life of the patient, because we didn't have any blood at the moment. Even there were not even units in the blood bank. So we said, yes, the patient is not febrile, so we don't think there are signs of infection going on, though he's been tachycardic. So we weighed options and said, as long as the blood seems to be fresh and it's not contaminated, we are going to try our luck and harvest and give him a chance. And we were a bit lucky, and he didn't have any other visceral injury. and we were able to get 2 pints of blood for the patient. So other tests in emergency situations done in advanced settings include even CT, which can even localize very well where the lesions are, the type of lesion, the severity, and even using all those specific degree of injury to classify the severity. But because of lack of having those technical staff, currently county doesn't have a radiologist, having a big challenge getting clear interpretation of these images or these findings, and even sometimes the machines are not familiar with the users. So we are trying to put up a team so that you can be able to address some of these challenges in future, and because most of these things will even lead to cost of patient's life. So that's why most of the time we even discourage now, if a senior colleague encounters the patient, the first time with the patient, he tries not to do all those all things like paracentesis, try to avoid those things. Use the clinical findings, how the patient presents, use the mechanism of injury to localize the probable location of where the injury is located, which visceral organs you have in that region, and are these organs able to lose all this amount of blood because they have a large vascular supply.
That's very helpful. I think that for everybody in the webinar, we want to make sure that, like you would do in any other case of acute intra-abdominal hemorrhage, you want to rule out the possibility of any injury that may contaminate the blood, in which case it is absolutely contraindicated to use the Hemafuse system at the present time. In the case of the ectopic pregnancy, because of the nature of the disease and the presence of the bleeding with no other injuries or any other possibilities of having a contamination, in that setting, it is safer and probably less difficult to proceed with immediate use once we know that this patient is coming with the obvious clinical presentation of pregnancy, shock, and a positive puncture or a positive ultrasound, as we discussed earlier. For the surgeons in the group in the webinar, it will be critical that even within the limited resources that you may have at your hand, whatever is it that you work, the moment that you can rule out any contamination, then you should be able to proceed and introduce the system to obtain autotransfusion. I don't know if there are any other, Emma, the audience is asking for any other contraindications for Hemafuse. Would you like to comment on those?
Yes, thank you, Dr. Puyana. Like you had mentioned, there's an issue of amniotic fluid. So we have two kinds of contraindications. We have the absolute, where you do not use the Hemafuse at all, and we have the relative contraindications. So this means it's at the discretion of the team whether to use. The benefits outweigh the risks. So in absolute contraindications, this includes sickle cell anemia. We have malignant tumors because of issues of metastases. We have bacteria. So if the site is contaminated, you do not want to increase the risk of septicemia. We also have bile irrigating solutions as absolute. So relative would include things like foreign matter. You have gastric fluid and suspected systemic infection. If they already came with an infection, say for instance, malaria, again, at this point, using Hemafuse does not introduce malaria the patient already had. So you just need to weigh whether the benefits outweigh the risks. Thank you, Dr. Puyana.
Thank you. There is a question for Dr. Kidalio. There is someone in the audience who wants you to tell us a little bit more about the clinical presentation of the patient with the bleeding from the ectopic pregnancy. How hemodynamically unstable was her? What was her vitals when she arrived? And how much fluid did you give her before you took the patient to the operating room? Go ahead, Dr. Kidalio. Let us know a little bit more details about your patient.
Thank you, Dr. Puyana. The clinical presentation, the patient came in with a history of increasing abdominal pain, vaginal bleeding, general body weakness, general lower abdominal pain, and a history of amenorrhea of 8 weeks plus. On examination, this patient was pale and in shock. She had a rapid pulse, and generally a rapid weak pulse. And the blood pressure was 100 over 50, 55, 60. And then generally our level of consciousness was deteriorating, was generally deteriorating. So on examination, we found a lot of abdominal tenderness and abdominal distension. Our vaginal examination revealed the hose was closed, but then we had there was some minimal blood on the examining finger. Then the adnexa on the left was tender. Then when I did the abdominal paracentesis, it was positive. I drew out some fresh blood. Yeah, and the fluid management, we gave about 2 liters before going to theater. And then in theater, the anesthetist took over the issue of fluid management.
Very well. Emma, there is people in the audience who wants to know the details about how many times can you actually reuse the Hemafuse system, what parts are easily exchangeable, and how is the cost of the equipment once you have it available, and the parts that you need to change. Can you tell us a little bit about the features of the reusability of the system?
All right, thank you, Dr. Puyana. So yes, the parts that can be reused up to 25 times, and I'll just show with my video. So you have the hard plastics as the components that can be reused. So this is the plunger, all right? So this can be reused. You have the collecting barrel, all right? And you have the nozzle, and then you have the O-ring. Okay, so just to help people remember, I usually say the very hard plastics and the rubber. So everything that was connected to the collecting barrel, that is the input and output accessories, those are discarded and are not reusable. Right, so immediately after use, it will follow the process of decontamination, washing, and then autoclaved. So the reusable parts are autoclaved at 121 degrees Celsius for 45 minutes with a dry time of 30 minutes.
And they're also asking if you need, when you add anticoagulant, what do you use and how much anticoagulant do you add?
So the blood bags, for instance, I'll talk about our setting in Kenya. The blood bags come loaded with anticoagulants. So that doesn't need anyone to feed anything. However, the Hemafuse device is not loaded, and we advise that it's not used for longer than 30 minutes, because after that, there's the risk of blood clotting within the system. So if you still need to use it after 30 minutes, so this is put aside and you open a new pack.
Oh, okay. That's very important for us to know. But I understand most of in the both cases that we heard today, all the blood that needed to be suctioned and retransfused was available quickly and took a lot less than 30 minutes, correct? Okay, I just want to acknowledge the presence of Dr. Carmen Hernandez from Spain, who has joined the webinar, and she has a lot of experience working in Turkana. It looks like she knows some of the people at the hospital. She's saying hello. So we thank Carmen for joining us. We also want to thank Dr. Rekar from Harvard, who is also with us and has given us a bunch of very interesting questions. So welcome to the webinar as well, Nakul. Tim, I'm going to move it to you. Let me know what else we need to discuss at this point.
Thank you, Dr. Puyana. There's one more question done directed for Dr. Khalid about whether a fast was done in this patient. Maybe you could ask that question to Dr. Khalid.
I think he showed the slides of the case with the fast. Dr. Hassan, you want to expand a little bit on your use of the ultrasound in your case?
Yeah, thank you, Dr. Puyana, for the question. So in our case, it was just normal ultrasonography, which was done. Initially, it wasn't our first scan, but the normal scan was able just to pick images showing intraperitoneal hemorrhage. But they were not able to do a first scan at that instance.
Okay. We clearly learned today that having an ultrasound available, even though it's possible, is not always an easy thing to do. And I think that we are used to have the machine right at our disposal. And it's clear that is not always the case in many places in the world, and that sometimes the ultrasound needs to be brought out of a room that is locked, that the radiologist has a key that is not available to all the clinicians. So even though the ultrasound may be present, that doesn't mean that it's easily usable. So we need to think about the context in which some of these adjunctive techniques, even though the hospital may have them, may not always be as readily available as we are used to see it in some of the hospitals where we worked. Dr. Rekar is saying that he's happy with the webinar and that was very informative. He's got one last question. Is there a concern that the blood exposed in the peritoneum can lead to fibrinogen or other clotting depletion? Do we have any information?
Maybe just to add, Dr. Puyana.
Yes, go ahead.
So the last study I shared with the members talking about a simple device for whole blood transfusion in cases of hemoperitoneum and hemothorax. In their findings, they looked at a number of parameters, biochemical parameters, and I noted that they looked at the bleeding time, pre-transfusion, post-transfusion, were they significant statistically? They looked at the platelets. They looked at the prothrombin time. So I think it's an avenue for us as a team, I think, maybe to look at this approach and see if we can be able to come up with maybe a study to provide and look into a number of biochemical parameters. How are these patients preoperatively? Well, how did the parameters look? Then using the device, this Hemafuse device, how did they correspond and what were the differences? Were they significant statistically? And I think it's an avenue maybe to be able to publish that.
That's very important. And I think there are many questions yet to be answered. We think that the system at this point is capable of saving lives as it works, that the instructions that have been given provide an extremely viable option to preserve blood and to reinfuse transfused blood in the setting of acute care where there is no other alternatives. And we are extremely excited about its availability. We go back to the question of Theophilus. He wants to get it. How do we go about getting the Hemafuse?
Dr. Puyana, on your screen right now is a slide sharing my contact information. My name is Tim Goodwin. I am the Senior Training Coordinator for CSU Global Health. And again, like Dr. Puyana said, thank you all so much for joining us today. If you have any questions regarding the availability, the pricing, and the purchase of Hemafuse, please copy down this email now and note that down, and you can reach out to me directly. You can also engage with us via the social media links or the people through which you have heard about this webinar. They can direct you as well. Just a quick note, Hemafuse is currently available for purchase in Kenya and Ghana. It has Kenya PPP certification and Ghana FDA certification. And we have distributors, local distributors in both Kenya and Ghana who have Hemafuse immediately available to purchase. If you send me an email, I'd be happy to direct you to the right course. The other thing I wanted to mention is that Hemafuse does have US FDA clearance as well. And so if you have any questions about availability, pricing, or purchase, please jot down this contact information here and send me an email, and I'll be happy to direct you.
One more thing, Tim, we will continue to put out these webinars, and we will continue to invite local physicians who have the opportunity to use it. Do you have any idea when will be the next time you will invite in order for the group to continue to learn from these?
You know, I actually don't. We are looking to feature theater nurses who have been integral. We know that doctors are, you know, sometimes get all the press, but that, as we heard with both these cases, both the surgeons in these cases were made aware of the device via the theater in charge. And so we don't have a date yet. We are working to put that together and get the presenters together, but the information around that next webinar, hopefully sometime in September, will go out via the same channels as this one here, the CSU Global Facebook, Instagram, Twitter, LinkedIn pages, as well as WhatsApp.
So stay tuned.
Exactly.
Okay. Anything else at this point? I think we have covered what we wanted to cover. I hope that everybody enjoyed the presentation. I want to thank both the speakers who share their experience with these difficult cases and their experience with the use of the autotransfusion system. Thank you, Dr. Hassan. Thank you, Emma, for these very informative video information. And also, I want to thank Major Dr. Ekiru Kidalio for their contributions. I want to thank all the people that came to the seminar, and we hope to see you soon. Not being anything else, I think we say goodbye to everyone. Had a good evening in Kenya and anywhere else where you are, and a good rest of the afternoon here on this side of the world.
From CSU Global, we want to say thank you for joining us today at our new webinar series, Saving Lives at Autotransfusion, Lessons from the Field. Thank you for listening to our clinicians as they spoke about their experience using Hemafuse. And if you're interested in hearing more from CSU Global and seeing other webinar series, please follow us on social media, Twitter, LinkedIn, or Facebook, and you'll be able to hear about future events, future training sessions, and future webinar.